TopMedTalk.
Nick Majerison here. This piece is presented by Mike Grocott, Professor of Anaesthesia and Critical Care at the University of Southampton, a frequent TopMedTalk contributor. Have a listen.
Troponitis, does it matter? Now, clearly this is a little bit set up as a pro-con, but I think I should reveal my bias at the start. It's not all about the heart, and I think that's important. And I think the focus on the heart may be driven by things other than actually the important things that are happening to our patients. So I've got a handful of disclosure. None of them are conflicts of interest. And this debate, to me, is about the tension between the heart as the primary focus of interest after surgery, or the whole body as the primary focus of interest after surgery. And it does seem cultural. So if I go to American meetings, there's much more focus on the heart. In the UK, we tend to focus on the heart less. And I'm sure they're unrelated. But I do note that in America, the cardiologists have gained significant revenue from doing cardiac consults around the time of surgery, and it doesn't really work that way in the UK. And I wonder whether some of that has driven some of this literature. So this is the definition of MINS. I'll come back to it in a moment to tease it apart. On the face of it, relatively straightforward. So an elevated post-op, high sensitivity troponin, and then you can see the qualifying wording there, which gives us this new clinical syndrome of myocardial injury after noncardiac surgery. And the straw man, if you like, is that MINS is common. Cardiac complications are common. MINS drives cardiac complications. This is a causal relationship, and therefore we should really worry about MINS and we should treat patients with MINS. And this is the sort of slide that you see relatively commonly in North America, and I suspect that North American visitors will recognize the individual whom I borrowed the words off. But there's high incidence of myocardial infarction, high incidence of mortality associated with myocardial infarction, and a real major concern that this is driving a lot of post-operative harm. And there's data, you've seen some of this before from Dominda, there's data to support this, so the vision data showing a relationship between troponin levels and mortality following surgery. This is some of the early data. This is the post-operative high-sensitivity troponin data. And you can see a gradient, so the higher the level of troponin in nanograms per mil, the greater the level of harm, to really quite significant extent. But these are the proportions of each of these categories as a percentage of the whole population. So there's only a very small number of patients in the very high-risk group, which is important to note, and I'll come back to it in a moment. So let's focus in a little more tightly on this definition of MINS. So it's an elevated post-operative high-sensitivity TNT with no evidence of non-ischemic origin, says that in the words just there, and brackets no evidence of ischemic origin. So that excludes, it says that the origin is irrelevant. So really what this is simply an elevated high-sensitivity troponin. You don't need any of the rest of the words because they're two mutually exclusive groups, both of which are not included in the definition. So if we look at the definition of myocardial infarction, you'll probably be familiar with this. And the ones we're talking about, so the ones that are not related to specific procedures, are type 1 and type 2 myocardial infarctions. And I think what we're primarily dealing with, I agree with Dominda after, in the perioperative context, is type 2. These myocardial infarctions related to imbalance between supply and demand within the myocardium. And the definition of myocardial infarction in these circumstances requires both troponin and another positive diagnostic test, or cardiac death, but another positive test, so a clinical finding. So let's have a look at troponin. So this is a study from Southampton by one of my colleagues, cardiologist, where he simply screened 20,000 inpatients, so 20,000 consecutive inpatients at a big teaching institution in the UK, Southampton Hospital, and looked at those who met the criteria for Troponitis, or if they were having surgery, myocardial injury after non-cardiac surgery, with a test with an upper limit of normal based on the notion that for diagnosis you're above the 99th confidence interval, the 99th centile for your population. So for this test, it should be 40 nanograms per mil. But it turns out that there's a very substantial number of patients in this population of unselected inpatients who have a value above the so-called 99th centile for a normal population. And in fact, the 99th centile for this population is nearly 300 nanograms per mil. If you, there you go, that's highlighted. If you exclude all the patients who had a myocardial infarction, so had diagnosis based on ECG or other scans or confirmatory diagnosis of somewhere or other, those figures are still pretty stark. So a very large proportion exceeding the diagnostic criteria for Troponitis, and a true 99th centile of nearly 200. And it turns out that critical care is a place where that's extremely common, and it's moderately common on the acute surgical unit. But patients who are sick leak troponin. That does not necessarily mean they've had a myocardial infarction. And if you look at it another way, based on based on age, you can see that the majority of patients have, even those with the highest levels of troponin, have not had a myocardial infarction. So it's been sought and excluded. And if you map that onto this data, a significant proportion of those patients that we are identifying, which is already a small number, are patients who have a high level of troponin that will not turn out to be a myocardial infarction. So are cardiac complications common? I'm not so convinced they are. This is some of the POMS literature, or this is the validation cohort for POMS that Monty and I worked on a number of years ago now. And the dominant complications using this set of criteria were pulmonary, infectious, renal, gastrointestinal, and that certainly fits with my experience. A significant chunk of my work is working on surgical high care, looking after sick patients after surgery, and we don't seem to see a high number of myocardial infarctions, and we certainly see a lot of this kind of stuff. And cardiovascular complications were relatively rare and a very small proportion of the things that were keeping patients in hospital. Brilliant study, brilliant author. The MET study, led by Daminda and Brian Cuthbertson, which I was also involved with. So big, major surgical cohort with a primary outcome, when we did the study, led from North America, of cardiac injury, although the initial primary outcome, when we first looked at doing it in the United Kingdom, was not cardiac injury, which I think is interesting, and I think you'll agree, the reason we made it cardiac injury is the funders will like it, and the funders did like it. So what did MET show? It showed a relatively low rate of death or myocardial infarction, and you can see that the outcomes broken out there. So only about 1.7% of patients having myocardial infarction, in comparison with a large number having myocardial injury, not entirely sure what the myocardial injury means, and a very large number having moderate to severe complications of the sort that I've just talked about, so pulmonary, infectious, etc. And if you look at the classification of those complications, look at point 1, mild complications, only harm that did not require clinical treatment. So a myocardial infarction that did not require any clinical treatment must be a relatively trivial event. How do we identify them? Well, we were doing ECG screening as part of the study. So these are myocardial infarctions that have only turned up when you look retrospectively at the ECG screening. And if you separate out the complications on that basis, it turns out that more than half of the myocardial infarctions were undiagnosed at the time. So there's a very low number and a proportion that's compatible with what we saw in POMS. So I'll put it to you, this is a relatively uncommon, significant complication in comparison with all the other complications that we're dealing with most of the time. And I close by saying a few words about association and causation and whether we have a myocardial injury, myocardial infarction, death causative sequence, or whether perhaps something else is going on that's confounding and explains this Troponitis. And one of the best ways of exploring causation is interventions. So what happens if you do give patients interventions, high-risk patients interventions that might prevent myocardial infarction and therefore add fuel to this story that there's a causal link? Well, it turns out with beta blockers you can reduce a little bit the rate of myocardial infarction, but of course we know that certainly in the way it was given in the POISE trial that kills people. Aspirin makes no difference. Clonidine makes no difference. Dabigatran might make a difference. So this looks like a statistically significant outcome until you note that the outcome also includes venous thromboembolism, so lumped in with myocardial infarction and stroke, which is unusual, and I don't think was the original plan for this study. And in fact, if you look at the cardiac outcomes from MANAGE, there's very little difference at all. So MANAGE is a great study showing that anticoagulation anticoagulates and reduces the level of venous thromboembolism, which was a big shock to many of us. If we look at blood pressure management, the IMPRESS study that some of you will have seen, a protocol to target a higher blood pressure, to better manage blood pressure using an infusion of a pressor, relatively small randomized control trial, really interesting study. They succeeded in getting separation between their groups, so having better blood pressure control against a specific target in the intervention group and the control group. And they succeeded in showing that there was a difference between those two groups in terms of outcome. So the individualized treatment had a lower level of the composite outcome, and it turns out that your kidneys are a little happier, your brain is a little happier, so altered consciousness is substantially rarer, the infectious complications and the lung complications are less common, and the heart isn't even on the page. There was one significant myocardial complication which happened to occur in the standard treatment group, but clearly that's non-significant. So what if just actually when you get sick, you leak injury markers from organs? Because all this literature has been about the heart, and we don't tend to look for kidney injury markers and brain injury markers, and when you start to look at the literature, and this is just an example, turns out the brain gets unhappy as well when you get sick after surgery, and that is associated with subsequent mortality. So maybe because we're looking at the heart, we're identifying the fact that the heart is a bit unhappy, but maybe all the organs are unhappy, and this is simply a marker of generalized inflammation and organ injury following surgery. So I put it to you that MINS is common, but all it means is the troponin's up. Cardiac complications are uncommon. Non-cardiac complications are really common and should be the primary focus of our interest. The causal relationship between MINS and cardiac infarction and death is not certain, and it's not all about the heart. I'll leave it there.
Lee Majerison here. Thanks for listening to TopMedTalk. Now, before we let you go, it's important that we remind you to subscribe to TopMedTalk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com and click on the section marked email updates. Finally, TopMedTalk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. EBPOM.org is their website. That's EBPOM.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMedTalk. That's ebpom.org/meetings.